Welcome, everyone. Today is September 24th, and you are joining us, and we are joining you this wonderful day in September. We are Emergency Medical Services for Children Innovation and Improvement Center. Today's topic is PMHCA ED Expansion Project Toolkit tutorial. Implementation phase. We will have an opportunity to listen to one of our participants from Tennessee, and she will represent Tennessee PMHCA. Her name is Angela Kanji, and she'll talk about herself a little bit before she'll present within the next few slides. Quick housekeeping. To some of the things to remember, please indicate your name, credentials, and affiliated organization in the chat as you're joining. We are welcoming all the questions. Please feel free to unmute or type questions in the chat. I will be joined, Angela, and I'm hoping a few folks from her team, but as well as a number of my colleagues, esteemed colleagues from EMC EIC, who will be monitoring the chat, dropping information with links as we're going to go through some of the elements of the toolkit. So please watch out for that. They also will be monitoring discussions and helping with questions if those arise, or hopefully those will arise, as this is meant to be an interactive experience. And with that, we're going to get started. Thank you for joining us today. Hopefully you are able to put your information in the chat. And welcome, Angela. So with this and with this information at the toe, we can go ahead and get started. So the toolkit, a little bit about the toolkit, the EMAC-EIC created for PMHCAs. This was a historical moment for us as we had to learn so much, but we weren't alone. We were joined by 6 teams at the time who were at the beginning of their stages of implementing their ED expansion projects and efforts. And with their help and through the numerous focus group discussions and their patience with us, we were able to pull out themes that we felt were important to highlight in our toolkit. This is how our toolkit emerged at the end of last year. And the 3 themes that were clearly underlined through those discussions were the first steps that are highlighted here: identifying the ED opportunities, evaluating your team's levels of readiness, and planning your team's work. With that, we've created somewhat interactive toolkit, and you'll see the image of it on the right-hand side. We will be dropping the link in the chat shortly. And it highlights some of the important steps to keep in mind. First of all, as you click on each, when you're in a toolkit and click on each section of it, it expands and gives you more information. So don't forget to do that. So the areas of highlight that we identified in our toolkit are capacity and capability, medical, legal, and reimbursement aspects, partnerships and collaboration, as well as technology. So evaluate the needs of the EDs is the first step. Learn to know the ED workflow is the next step, and conduct a needs assessment, as we feel is one of the first more important steps. We also outline the aspects and strategies how to go and doing things. And actually, it does say in our toolkit what to do. So when you're in a stage, what possible things to consider, what pathways to evaluate, and ways to support EDs, as well as exemplars of how, based on the work that's already happening within your team, how this work could be an add-on to your future steps with AD expansion. We also have created team activities for each page in our toolkit. So one of them I'd like to highlight here, especially with implementation strategies. Some of the important steps one should think of as you are planning this work, and I probably wanted to add this in the beginning, are the stakeholders. Do you have stakeholders, partners that you can connect with that have connections to your hospital departments, ED departments? And then based on the connection with the stakeholder, which is, I think, is the most impactful step, is what data and what are the struggles that our ED are going through are the next steps. It has been our experience that having someone who works for the hospital system, with a hospital system, advises to the hospital systems, having somebody like that on your advisory board is one of the essential steps. And throughout our Angel's presentation, we'll have an opportunity to kind of experience what the Tennessee team had experienced and stakeholders they had on their advisory boards. So with that, one of the activity we suggest to do is to evaluate the staff, the space, the systems. So with the stuff, we're looking for using our toolkit, right? The first step. That helps you to kind of get to know what is available, what might be needed, gives you ideas on where to go. The staff, do you have a personnel, folks that are having the skills to do the needed work? Does your team already have somebody who is skilled in, for example, communicating your work to the ED departments that you maybe already have done in the past, or advertising the available services? So that's one way of looking at this. Also, looking at your team's pathway of interests. And with that, we talk a little bit about this in our toolkit, but also throughout our collaborative this past year, we've looked at, are the services you're going to offer going to be educational pathway, education related for providers, or are there going to be services related? Something that Angela is going to touch base on today with her work at Tennessee PMHCA. And then spaces, are there engaged stakeholders? Who can you tap into your department, your related affiliated university that may already have somebody who can connect the dots for this work in your state, and the systems. Folks, it's a complicated, those are complicated systems. Our healthcare isn't easy. So contracting with hospitals will take time. So be prepared and allow time for this is essential depending on the services you will provide. And of course, it will take legalities, right? Because it is a complicated system. And with that, our next page is going to be just a reminder of the toolkit. You can scan the barcode here as well. And I will, if there are questions, please type them in the chat. If you guys want to come out and unmute as Angela is providing information about the work in Tennessee, please do so as well. And with that, I'll give you Angela. Take it away, Angela.
Hello, everyone. Thanks, Anna, for having me and the opportunity to present TCAPS and to tell the whole world, everyone who's listening, how far we've come, and if there's any way we could make suggestions based on the progress that we've made in our program. Always happy to help. So my name is Angela Okonji. I'm the program director for the TCAPS program. We fondly call our program TCAPS, and it stands for the Tennessee Child and Adolescent Psychiatry Education and Support. We got funding from HRSA in 2021, but our program did not officially kick off for the PMHCA. Our program did not officially kick off until 2022, 2023, because that's when we spent time hiring staff. I'm here today with Carolina Clark. She's the principal investigator for the program, and Christina, who's our epidemiologist, our program epidemiologist. So that's kind of like the brief introduction of who I am. Next slide, please. So we started our ED plans, our ED projects. When I was talking about how we started in 2022, 2023, I was talking about the base program, the base PMHCA program. So we expanded into the ED space. We got funding for that September of 2022. And then HRSA also puts the EIIC as our TA, and we're working with them with our initial challenges and struggles. So that was kind of like our path. So next slide. So I could have my talking points for this slide. So like I said, we received HRSA funding in September of 2022. We leveraged on our partnership because our base program, we already had partnership with the University of Tennessee Labano psychiatric specialist, and then the Methodist Labano community outreach. All of these are kind of like a network, hospital network. And so we leveraged on that and then extended a hand of partnership to the Labano Children's Hospital ED. They had already received external funds for universal suicide screen. So we're looking for a point where we could partner with them and provide what their funding could not cover for. So what we did was we partnered and provide half FTE of the social worker that will be involved in the follow-up of patients discharged with a safety plan. And then our partnership has resulted in embedding universal suicide screen into their electronic health record and protocol. So we started out with drawing a plan. They had this plan and then they got funding for that, but we're leveraging on that because that was what the whole PMHCA program was about. And then since we knew that the ED was kind of like the space where a lot of suicide-related activity, like when people have that suicide or near suicide attempt, that was kind of like the first port of call. We knew that it was a good place to catch or to provide services. So that led to our partnership. Next slide, please. So the data that we use to influence this implementation, our state uses an ESSENCE data, and ESSENCE stands for the Electronic Surveillance System for Early Notification of Community-Based Epidemics. We use that for other things like flu and some other diseases and infections. So ESSENCE is also used for our suicide-related project. And data has revealed that higher suicide rates in children aged between 10 to 24 years was from a certain county in the western region of the state. And it was as a result of the data that we had that we started our pilot study for the PMHCA program, and then by extension, leveraged on all of those factors that we had earlier stated, and branched out or expanded into the ED space. So how does all of this system come together, like our base program with our ED program? So we follow up patients who screen positive on a depression suicide risk screen, and we're discharged home with a safety plan. Our medical social worker makes several attempts, 2 phone calls, 1 voicemail, and 1 text message. And then reaches out to the family of the patient that was discharged with a safety plan, and then just goes over kind of like she has a worksheet where she goes through the safety plan and ask if they have been able to link with a primary care provider, schedule an appointment. Also, our program is working with Labrana on a warm handoff, including introduction of our program to primary care providers of the patient that was discharged with a safety plan. And also, Labrana will include information on our program in discharge summaries that are sent to primary care providers. So that's how we're connecting our base program to the program that we've set up within the ED space. Next slide, please. Plans for expansion. Everything is always dependent on funding. Currently, our funding source 100% is from HRSA. We're hoping that by the time our program has run for quite a while, data will show on the importance and the need for our program, for continuity of our program, and probably draw on state funding as well. But all of that is still kind of like being hopeful. So everything is always dependent on funding. You could have the best plans, but if you do not have money to match the plans, well, they are just plans. Our accomplishment so far has been that we have implemented universal suicide screen for all pediatric patients 11 years and older seen at the Lobano ED. And we have also improved the follow-up of children with mental health concerns after they were discharged from the ED. Also, our partners at Labrana Children's ED is extending this screening to inpatient setting. The way it started out, it was just screen every patient who comes in, except maybe after triaging, you see that screening is not the top on the list. This patient has to have medical attention. Other than that, it's relatively 95% of patients who comes in that receive screening for suicide. And now, apart from within the ED space, they are extending the screening to even patients who are in the hospital who are not within the ED space. Also, our partners at Labrana have embedded this universal screen into their electronic records and their protocols. This project has resulted in lower holding times for patients not being admitted. So before this project was instituted, patients who come in with suicide-related complaints, and sometimes there's really no holding place, like they haven't quite decided where to place them, and they don't feel like it's safe to send them home. They could stay in the hospital anywhere from at least 13 hours, and some kids have even stayed in the hospital for months. But with this project, there are lower holding times for patients. The social worker is able to call on, we have the mobile crisis that takes patients who have 10K. 10K is what the term we use for Medicaid in our state. And then people who don't quite fit in, calling inpatient places where they could like fit in. So they are just lower holding times for patients that are not being admitted. Now, holding times is as low as 6 to 8 hours. Also, our social worker has been able to follow up and connect with families most of the time. There have been families where they placed that call and there was no response even after the initial phone call and a text message and all. But in almost 90% of cases, we've had families take that call and then that follow-up has occurred. Next slide, please. So our future expansion plans. We are very happy about what our project has been able to achieve so far. In addition to what we can, with what we've stated as our accomplishments, our partners at Labrana have also, as a result of this project, and then just thinking broadly, has constructed safe rooms within the ED space. So and this emergency room spaces have significantly reduced ligation risk. So they constructed these rooms with safety of suicide related health ED visits in mind. Also, inpatient behavioral health social worker has been onboarded. We were only working with one social worker, but now while increasing the staff strength, there has been system-wide behavioral health model implementation for Lobana to include all of this in their inpatient, outpatient, primary care, and their psychological division, the division within the ED space. Then also, they are partnering with Living Well Network. And the whole essence of this partnership is to connect pediatric patients with mental health care providers in the community. So all of this stemmed from this program, and this is how far we've come. Next slide, please. So what we at TDH hope to do, we hope to share our project findings and support the implementation of universal suicide screen in other pediatric EDs. And like I said earlier, everything is based off of funding. We hope to model like what we've seen and tell other ED places that this is possible, and this is what has happened in one ED, and we can replicate it someplace else. But of course, everything is based off of funding. So next slide, please. And that's all I had. This slide shows all our partners, both for our base program and our ED projects. So thank you.
Thank you, Angela. I'd like to go ahead and open the floor to the table, questions, questions in the chat, questions. Just unmute and ask questions. I do have one in mind right away, but want to give the folks opportunity to jump in.
There are no questions in the chat right now.
Okay. So this question is for Angela and the team. What were the two, if you were to point out two out of looking back at the processes and how things were established, what were some barriers and opportunities that you thought you would want to share with yourself like a year from now? What would be something that you would want younger yourself, your team, to be aware of and maybe warn others? If you were to point out two, that would be great.
I
Two
would
barriers.
I would say number one is always have someone on the inside. Like, there's no point making plans and needs assessments on how things will work within the ED space without having leadership within the ED space in on the team. We had plans to train ED staff in addition to providing the safety plan, follow-up for safety plan. But our inside person in the ED space was the nursing director. And since our training was kind of like directed towards, initially, it was directed towards ED staff, the physicians, and we didn't have anybody representing this group of people, professionals at the table. It didn't seem like maybe we were really meeting the needs that they wanted. After we spoke to the nursing director, set up a meeting with the CEO of the ED, and he didn't think that was what they needed. Like, he didn't think that what they needed was the training we were offering. Although we knew that there were difficulties with setting out time, so we wanted a self-paced training, or we thought that a self-paced training will meet that need, but they didn't think so. They didn't think that was what they needed. So I'm just saying that we wouldn't have gone so far into making such plans if we had someone seated at the table from the beginning, kind of like the stakeholder, drawing a stakeholder plan and saying, okay, this is who needs to be seated at the table when we're making these plans. So I would tell my younger self that we need to kind of like do a mapping and know who needs to be seated when these decisions or thoughts on how we are going to plan takes place. And then next, I will also say give it time. A lot of times it felt so frustrating that these are different organizations. Every organization have their own individual protocols on how things work within their own setting. And then you propose a meeting or you propose kind of implementation of something, and that thing still has to go through leadership in this other organization. And then all of them have their own individual protocols. So sometimes it's almost like you're waiting for months for something to get done. And it's like, oh, this time is going, time is of the essence. We're almost midway in the first year of our program, and it doesn't seem like we've made much, we've made much progress. I would say to my younger self that time is always needed all around. Give people time and give project time to kick off. Everything takes time.
Thank you. And what helped to have like the first what was the catalyst for having the correct stakeholder at the table? What helped your team?
Um,
Or I would say
like
the
I
most
said,
impactful, impactful stakeholder at the table.
the stakeholder we had, the nursing director, she's still like, we still have that partnership ongoing. She's a great stakeholder at the table for the follow-up implementation of the universal society screening. But when it came to that piece of having training for the ED providers, we didn't have anybody represented there at the table. So that was where that mix-up came. For the follow-up safety plan, follow-up and universal society screening and implementing that and having that in the protocol, that worked fine because we had what we needed. We had the nursing director. But when it came to the training, and since we wanted training related, we wanted training of ED staff, most especially we're targeting the physicians. We didn't have anyone represented from that group at the table. So although we tried to schedule meetings in between, that didn't quite work, but we just got the feel that that was not what they were needing. That was just the general message, that the plans we had was not what they think they needed. What they felt they needed was a way to get patients who came into the ED with suicide-related issues, behavioral health challenges, moved on to inpatient care, moved on, like after the first kind of few hours where they attended to, they needed them to be, their care to be taken over by the experts. That was what they felt they needed. They didn't really want to be actually directly handling those patients. But I think there's always room to explore options, like being in with the EIIC this long and having Ryan. There's Ryan from North Carolina, listening to how things are done in North Carolina. It's made me think that we could still have something that is outside the norm, thinking outside the box, and still make it work. But anyway, like I said, you could think these things within the four walls of your office space. But if stakeholders who are actually going to be boots on the ground are not seated at the table, then you might just be thinking needs that other people think is not what's necessary. So
Thank you, Angela. Are there questions in the chat?
No
Don't
questions in the chat.
Don't
But I
see
did
it. Go ahead.
no, but I did share the link for North Carolina, their program, the NC STEP.
Oh, great. Thank you. Thank you, Hannah. Angela, I do have a little bit of a technical question, and then I'm hoping I have a few other folks from EIC that are close to ED space. They'll jump in with a few questions, but I wanted to ask how is this the social worker that is sponsored by this program, um, is there a physical location on the in hospital on site, or are they remote?
Physical location on site.
Okay. Do they then have an opportunity to introduce themselves to the families and the children there, or not necessarily? Because often I'm met with when I listen to pediatric mental health care access programs, the obstacle is if folks are thinking that, ED 24/7 operation and PMHCAs are not. So how were you able to overcome this or mitigate it with the social worker there on site?
So that's a challenge. The social worker on site works 8 to 4:30 weekdays. So the ED space is not really covered. Like the covering of what she does. There's no covering for that in the over the weekends and after hours. So that's the need for this second social worker that was just recently hired. But before this new social worker was onboarded, what happened was that when she resumes the following day, she tries to go through medical records to see what she might have missed. But of course, there's always the chance that one or two records might have been missed. So she tries to follow up on patients that came in with suicide-related challenges that she has to follow up on.
Okay,
And
so she
Angela,
does it the day after, correct? Is that
Can I
Yeah.
because Ashanti's actually on, just in case. Don't want to put Ashanti on the spot, but in case
Oh, she's on. I didn't
yeah,
realize
in
she's on.
case
Okay.
just in case she wants to add anything to her
Yeah.
interactions with
Hey,
families.
it's Ashanti. Yes. So, yeah, I work 8 to 4:30 Monday through Fridays. When I leave, I try to finish my cases up before I leave, but if for some reason I can't, I do hand it to the next shift social worker. And they usually finish up things, or if a new patient comes in, overnight or after 4:30, they'll kind of go ahead and get that process started. I have a binder that I leave down in the emergency room in the social worker's office where it has all the resources they need to move forward with that treatment plan. Now, when I do come in the mornings, I do follow back up with my kids from the previous day.
Oh, thank you. That's wonderful. Good information. Thank you. Appreciate it. Okay. Any questions to either Carolina or Ashanti or Angela? Discussion points, any clarifications? This is the time.
Okay, I'll step on. Here, I'll turn on my camera. I'm Angela. Part of the EIC group. I had a question to clarify, because I know that a lot of our PMHCAs have had trouble. We've talked about this, of kind of like getting in with the emergency departments. So Ashanti, are you seen as a member of the emergency department, or are you kind of a consultant, and how do you kind of sell your role to everyone?
Yeah, I am.
Oh, you muted yourself.
Thank you for that. So I am a part of the emergency room, but I am still on the social work, under the social worker department. So I do have a social worker director and lead. So I kind of, when I first started, they introduced me as, the new and the first behavior health social worker. So everybody kind of knows who I am around here. Did that answer your question?
Yes, thank
Okay.
you.
Mhm.
Hi, this is Margot Harwell with Alabama PATHS program, and our hope was to provide training for some rural emergency departments. We've done a lot of outreach, don't really have anybody on board yet with that, but we're also providing our consultation line for boarding emergency room pediatric patients. Those are the two things that we're trying to promote. We're willing to be flexible and adjust. And it's interesting to me that you talked about the training offering not really taking hold. I wonder if you have any more detail about what you were recommending as training or what you were offering from a training perspective. And you mentioned that they said they didn't think they needed the training that you were offering. So I guess that's why I'm wondering if we can hear specifically what training did you offer, and did they make suggestions on what training and the format of the training, what would be helpful? And I think just our focus might be a little different because we're already in a children's hospital that has a pretty robust behavioral health department and inpatient care, and ED, we have a whole ED wing for mental health patients. So that's, I think our focus is more including rural hospitals. So it would be a training for small hospitals around our state. So anyway, just more reflection on that if you have time.
Well, your setup looks more detailed with the fact that you have your ED wing and behavioral health consultants. The ED space at Lobano, up until recently, because now they are thinking of having a psychiatrist on staff in the ED space. We were thinking of training the ED physicians on behavioral health, but it wasn't received. And what we proposed was that they have a self-paced training, and then the psychiatrists, the child and adolescent psychiatrists that already man our consult line, have a Q&A with them where if there's a question on maybe case-by-case basis on something they've seen, how they could have handled it, or something that they is frequently seen in the ED. But I just don't know what it was. It just didn't kick off. They didn't think that that was what they needed. And so we are still rethinking how that training can work, or if it's something that we should just put in the bag altogether. But yeah, they didn't think that that was what they needed. They just felt that patients needed to be in the ED space. When do you have such patients in the ED space, they just need to be moved along into inpatient, or after kind of like the initial caregiving or care provided, that they just needed to move them along. And that was what they needed, like a way where patients did not have to be held in the ED for so long. That was what they felt was the need for them, not training.
Yeah, I was just going to add, it was just an example of just having to be flexible and adapt, as we originally thought that our team of child and adolescent psychiatrists who manage our psychiatry consultation line would be able to train the group of ED providers, and it was just really difficult to schedule that and to make that work. So as another alternative, our ED partners in Lobano identified a self-paced training course, which I believe is what's being utilized now. But then more recently, they have asked us they've expressed a need for training for first responders. And so we are helping with that, with supporting that training. So basically just being flexible and just, you just inquiring, what are the needs, and just making those adjustments.
Thank you, Carolina, for reminding me about that. Yes, I forgot that piece about them later asking for training for first responders. And then nursing director, the reach we had there, our partner there, told us that what they were thinking we could adapt into instead was kind of like having a go-to team where you have a team of physicians and then nurses, just form a team where if there's any behavioral health related issues, these are the ones that the other staffing members go to. That could better address the need for that training piece. So just being adaptable as the need arises.
Thank you. Margaret, did that help answer your question?
Well, it's got my wheels turning. You know, I love the concept of the first responders training. If you have any more details about that, I'd love to hear about it, because in our effort to reach out to rural hospitals, maybe that's a way we could assist them, is by training some first responders in the area around these small rural EDs. I don't know if anybody has a thought about that.
Carolina, you want to speak in regards to the first responders?
Yeah, if you guys want to share anything you've started already or thought of, what are the ideas?
I can put a couple options in the chat. You know, there's one training called the assist training that is a suicide first aid training, not exclusive for first responders, but there is an evidence base for its use among first responders. And then there is also a National Association of Emergency Medical Technicians Mental Health Resiliency Officer training. That's another option. Also these peer support classes. So I can put a few links in the chat as far as some of the training opportunities that we're exploring.
Thank you. All right, we have another few minutes for questions before we'll jump into evaluation and wrap up. Are there any questions or suggestions?
Okay, I have one more question, just to keep it going. You mentioned that you have, so I think that if I was an emergency department, my goal would be, to make sure that the patient and staff, are getting the care that they needed and are happy with their jobs, and that you're doing what is best. So it sounds like you're kind of helping protect the first responders, of helping them feel competent and talking about suicide through the assist training and the resiliency. Sounds like you've embedded kind of an at the elbow kind of support person in the emergency department and reduced length of stay. And so like giving them the resources, and kind of reduced length of stay. And maybe, training the first responders in assist, or kind of what your processes are, might prevent even kids coming to the emergency department. What are you said you're collecting the data. So what data, where did you go to get the data? And, is there any guidance that you can have around, around what keywords or what things that you talk to the emergency department about to be able to collect that data? Does that make sense?
Yeah, it does. The data has been relatively crude. We haven't been very detailed. Ashanti has just kept kind of like an Excel sheet, but we had a meeting recently with the EPI, and Ashanti. We had kind of like a group meeting trying to find what data we could collect without getting too much PII. So we are exploring, because we just want to get enough to show that the program has been effective. But if HRSA is not requiring so much, we do not want to take too much that is like we have too much PII and we do not really know. That's not necessary, like having information that is not really necessary for what we need it for. So right now, data that has been collected has just been related to patient, the reason why patient was, I think Ashanti can speak to the data, because she's the one who's been collecting that data. Ashanti?
So the data that I collect are for the caring contacts or the follow-up, all the behavioral health kids that come to the hospital, whether it's in the emergency room or inpatient, social workers send their name and information to me, and I wait a few days, and wait about 2 or 3 days and call the family to see how the kid has been doing and to see if they got connected with follow-up services. If not, then I'll get the email and I'll email the mom some more services, or I'll make some referrals online. But I usually collect that data on a spreadsheet, and I'm able to get in contact with, at least 90% of my kids. So that has been going pretty good.
Yeah, that is good. A lot of people say they have trouble reaching the families after they discharge, so that's good. So what I'm hearing you say is just it takes a lot of kind of the creativity and kind of just working with the systems you have. There isn't a magical way that you pull the data or anything like that. It's all just manual.
Yeah, not a way that I know of, because I'm a social worker. But yeah, so that's how I do mine's for now with my data.
All right, thank you.
Okay. We're gonna go ahead and start the evaluation. Please take